Thank you, dear. Good day, everyone. Good morning, good afternoon, good evening. And thank you, OncoDaily, for the initiative, and especially Gevorg, Dr. Tamamayan, for the invitation to discuss a topic dear to me since I was a fellow, and to discuss global equity of clinical trials. And actually, it comes right in place after the great discussion I just heard from Mrs. Green about V Foundation. I was just wondering if V Foundation would be open for funding research globally outside the US. You are doing great job, by the way, supporting equity in clinical trials in different populations, geographic distribution in the US, wondering if you could extend help across borders. So I will be discussing the topic starting by definition and the importance of the topic, moving forward to discuss challenges and barriers, and finally addressing potential and opportunities. So what is global equity clinical research? It talks about ensuring fair, not necessarily equal access to clinical trials across diverse populations and regions, to reduce disparities in terms of trial participation in terms of geographic distribution, to ensure inclusiveness from countries of low and middle income, to ensure inclusiveness of different ethnic, racial, or socioeconomic groups usually less represented in clinical trials. This is what global equity in clinical trials is about. And why is this important? It's very important scientifically to ensure the data is applicable, generalizable to different populations. It is applicable in different environmental and genetic contexts. It's important because it's an ethical responsibility to ensure the principles of fairness and justice in global health. And above all, it's very important to have a real impact globally to improve patient outcomes. It's important to address unmet needs of less represented patients in terms of clinical trials participation. It's important to bridge, to use innovation to tackle those unmet needs among less fortunate societies in low and middle income, I would say communities, even in high income countries like rural areas, for example, even North America. It's important to bridge the gap between patients and investigators across different economies. And indeed, we do have a challenge. The reality is that despite the fact that 2/3 of new cancer cases diagnosed annually are diagnosed in countries of low and middle income, you'd be surprised that 80% of the clinical trials conducted are being conducted in countries of high income. As you can see here, over the past 2 decades, most of the increase in the number of trials conducted is in high income countries, North America, Western Europe, and Japan. There has been a promising trend in increase in the number of clinical trials in countries of upper middle income, represented by the orange line, lower middle income, but no change whatsoever over the past 2 decades in countries of low income. And just remember, the bulk of patients diagnosed with cancer is actually in these countries. And unfortunately, the future does not look bright. The prediction for the next decade is to have a significant increase in the number of clinical trials. But as you can see here, most of the increase is still in North America, much less in Europe. In North America, you're expecting to see almost doubling in the number of clinical trials. In Europe, there is an increase, but not that much. The only positive impact, as you can see here, has been seen in increasing the number of clinical trials predicted to be carried actually or conducted in Asia Pacific, but no change whatsoever when it comes to Latin America, Middle East, and Africa. And again, the bulk of patients, 2/3 of the new cancer cases are right here. Dark blue, as you can see here, darker blue, and black. the number of clinical trials is trivial. You're talking about less than 10% probably of the new clinical trials to be conducted in the regions that host, unfortunately, 2/3 of the new cancer cases worldwide. And we are discussing colorectal cancer. As you can see here, more than 2/3 of the new cancer cases are diagnosed in countries of low middle income, with a parallel number of cases lost to colon cancer annually also in these countries. And yet, if you look at the proportion of industry-sponsored clinical trials focusing on innovative therapies during the period between 2013 and 19, only 5% of those trials had one site in a middle-income country. Only 5%. And 50%, almost 50%, had one site in middle-income countries. However, if you dissect these numbers, you would see that most of those countries are upper middle income. Mostly, you would see Russia and China there. And in countries of lower middle income, most of the time, it's either Ukraine or India. Most other countries are not represented at all. And as you can see here, none had any site in a low-income country. And reasons, most of you practicing in countries of low and middle income, you would expect the barriers, and you have probably lived through these barriers. Reasons start from governments. Most governments indeed do not have any regulatory requirements, not because they're easy on clinical research, but because they do not look at clinical research as a necessity. They look at clinical research as a luxury in terms of clinical practice. No need for clinical research. Let's focus on clinical practice. So really, there are no regulations to allow for conduction of clinical trials. And when regulatory requirements are in place, they are costly, very tedious, long, very dismissive, actually, for the researcher to go through. So unfortunately, they do not encourage research. Indeed, they discourage researchers from going through these regulations. And of course, there is lack of internal funding to support research infrastructure. Therefore, clinicians, faced by the lack of funding internally, try to move to international funds. We just heard beautiful work by V Foundation to support clinical research, but international funding is not easily accessed for researchers in countries of low and middle income countries. And when they do, most of the time, it does mandate having research experience, which is quite limited, of course. And most of the time, the condition is to have a high income institution to support that research. And when that condition is there, unfortunately, most of the funds would go to the institution in the high income country with much less compensation for researchers in countries of low and middle income for their time because of lower salaries. And that creates another hurdle, which is the lack of supportive staff. You need supportive staff to support the clinician who is already busy in daily clinical practice or even in academic institutions with their teaching duties. So they need supportive staff to go on with their research, or to carry their research, or to have a meaningful time to carry meaningful research. And to add to complicate the matter even more, a recent survey of contemporary clinical trials which has been conducted in countries of low and middle income demonstrated that only 8% of those clinical trials had the lead author, one of those in countries of low and middle income. Most of the time, the lead author is from a country of high income. And when those lead authors manage to publish their work, you can see here, most of them, they managed to publish the work in journals with less impact factors as compared to researchers from high-income countries. That's another discouraging reality and fact we live through. And yes, we're still motivated to have access to innovative medications for our patients through clinical research. And indeed, this is a reality. even in Australia, not necessarily only in countries of low and middle income, 50% of patients eligible to receive cetuximab in Australia managed to access cetuximab between the period of 2005 and 2009 through two programs: the Interim Access Program for colorectal cancer cetuximab, and through a phase 3 randomized study, 4 years. But the good news is that 4 years, 50% could access the drug when it was not funded. Can you imagine? And after that, it was approved and they could access it. For us, we are very hopeful to have clinical research help us access innovative medications for our patients, but we have ethical dilemmas, a lot of ethical dilemmas. The first one is, once the trial is completed, how can we have access to the drug hopefully approved for the patients who are already on the clinical trial at least? If you think about approval is like a marathon around the globe, and particularly in countries of low and middle income. Most of the time, companies are not interested in even submitting the papers for approval because of limited financial return. And even if they do, lots of requirements, the review process is very complicated and prolonged, takes at least 2 to 3 years, probably because of less trained staff. Sometimes, as we mentioned earlier, strict regulatory requirements. And once the drug is approved, it does not mean patients can access it because it's not on the essential medication list for the country. And so patients have to pay out of pocket. And we all know the price of new medications. So the ethical dilemma of putting patients on a clinical trial for new medication, they are responding, the trial is complete, the drug is approved. And what can you do to support your patients get the new drug? And as we mentioned earlier, approval does not mean access for the patients. And that creates another challenge. The control arm in countries of low and middle income is not necessarily the best standard of care you rely upon in countries of high income. For example, in the world of breast cancer, where patients, for example, in the metastatic setting, receiving a single agent hormonal therapy in countries of limited resources, as opposed to CDK4/6 inhibitor with hormonal therapy in countries of high income. They are both acceptable standard of care. But can you compare a new innovative medication to the minimum standard of care? That's because the best is not available in countries of limited resources. Most of the time, companies are not willing to support the control arm medication because it is expected to be standard. So would access to innovative medication justify the control arm to be less than the best standard available? That's an ethical dilemma. And indeed, the Helsinki Declaration does not approve of having a minimum standard as a control arm. That takes us to barriers related to patients. Still, lack of funding is a barrier wherever you go, even for patients. Usually, clinical trials mandate frequent visits, extra tests to be done, and transportation could actually be an issue for patients. That could mean more time taken from work. So patients need even funding at least to compensate for those extra visits that are not usually needed in regular clinical care. Again, patients in countries of limited resources have distrust in the health system. And when they hear the word clinical trial, they think of themselves as quote unquote guinea pigs being used to try a new medication. And that mandates awareness and education. And you would be surprised, in many countries, talking about clinical trials in social media or even in regular media is actually prohibited and can be punished by law. So how can you educate patients about the importance of clinical trials? How can you make them aware? And that creates opportunity for creating advocacy groups, having those advocacy groups on board from the inception of the trial, through the approval process, through the conduction to support the clinical researchers. And in addition, consent form has to be culturally appropriate and very clear. Still, countries of middle income, at least, probably this hurdle is being overcome with more and more patients understanding and reading and getting more information through social media about the importance of clinical trials. Finally, from the perspective of industry, of course, you'd expect them to be concerned about site and researchers. And indeed, their main reservation starts from having infrastructure. Do we have hospitals, clinics, well equipped to carry those clinical trials? Do we have enough staff? Not only is there is a limited number of clinicians, but also even more limited number of those clinicians interested in research, and more limited number of those clinicians interested in research having the appropriate training to carry that research. And for the obvious reasons we talked about, particularly lack of motivation. And when it comes to conducting clinical trials, you need to have accredited labs, radiology centers, enough supportive medications, not only medications, not only the cancer medications, but even the supportive medications for the patients to help them through the journey of treatment. And finally, patients and the supportive patients compliant with treatment, with follow-up to have credible results to ensure their investment is not going in vain. And indeed, we have been talking about barriers from different perspectives, but these barriers actually do have potential. Potential starts by having a network of research centers with a master agreement and adaptive design specific to each center. Of course, that needs government agreements, especially when you want to have a network among centers, not necessarily within the same country, but across countries. So starting with master agreements with adaptive design probably could overcome some of the regulatory requirements. And we need to establish policies to motivate staff at the level of the country. They need to be motivated morally, acknowledged for their efforts, physically having supportive staff, and financially, involvement has to be rewarded, and they need to be compensated when they are getting funds similar to colleagues from high-income countries. And their effort also has to be addressed in terms of publications. They have to be in the right place according to their contribution. And we need to limit, quote unquote, trial parachutism between high-income and low-income researchers. And when it comes to industry, they can look at the limitations in terms of infrastructure as an opportunity to build and sustain a good infrastructure, not only for research, but also to improve clinical services in the countries they are conducting the research in. Particularly, 2/3 of cancer patients worldwide are in these settings with limited resources. And finally, we need to work on supporting patient advocacy groups, having more and more advocacy groups in each country, and those themselves can spread awareness to the community and to the patients. Meanwhile, until we have those ambitious dreams in place, what can we do? I believe high-income investigators can support and understand the needs of their colleagues, and investigators from limited resource settings need to be assertive in terms of their needs, collaboration, and get support from a lot of excellent colleagues in high-income countries. Also, we need to focus on relevant clinical trials. Those are practical clinical trials. They are fair to the control arm. It's not going to be a disadvantage. And mainly, we need to focus on the escalation trials. The shorter duration, for example, in the setting of colon cancer, shorter duration of adjuvant therapy, 3 versus 6 months. And interestingly, those trials have been carried in high-income countries, focusing on the frequency and schedule, particularly the alternate week schedule of capecitabine, rather than having 2 weeks on and 1 week off, and that proved to be non-inferior with less toxicity. Excuse me for the typo. And the dose too. We all are familiar with the toxicity of capecitabine, and most studies have demonstrated higher tolerability in Southeast Asia as compared to North America. So lower dose of capecitabine address the outcome. That can be easily done in countries with limited resources. It's practical. It has actually impact for patients around the globe, not only in countries of limited resources, and it's feasible. Finally, to conclude, to solve the puzzle of global equity of clinical trials, we need to come together. Governments, regulatory agencies, pharma, and civil societies. We need to work together, keeping in mind this is an opportunity to build sustainable infrastructure, to improve our infrastructure, not only in terms of hospitals, clinics, labs, radiology, but also healthcare workers. Those are going to be educated not only in clinical trials, but also in better clinical services. It's an opportunity for mutual win-win collaboration between high income and limited resource setting. It's a win-win situation. 2/3 of the patients are in limited resource setting. So for the clinical trials to be to enroll faster and get results faster, they need to have those patient pool in these clinical trials. That allows access to new medications, but pharma has to address the ethical dilemma of sustained access after completion of clinical trials, and we need to be practical and focus on relevant clinical trials. With this, I conclude and thank you for listening.
Thank you very much. And we actually have two questions. One is for Dr. Greer and one is for Dr. And one is for Dr. Al-Sukhun. So I think we should move forward with your question and then we will get back to Dr. Greer's question. So how do researchers from low and middle income countries compete with those from high income countries if their opportunities and access to equity is limited to begin with? How do we overcome the mistrust in accomplishing a project in resource limited settings?
Well, that's what my talk was all about. Simply put, you need to be part of the bigger societies, get to know sources of international funding, and get to know reliable colleagues. You need to work with colleagues from high-income countries that have mutual respect and trust. And you need to be part of the bigger community. You need to be part of societies like the American Society of Clinical Oncology, European Society of Oncology, and look at international opportunities. Right now, whether you're talking about ASCO or ESMO, they have international groups. I'm actually proud to have been a member and chair of the International Affairs Committee at ASCO, where I met great colleagues, learned about opportunities, collaborated with so many across the globe. You need to be part of your global community to learn more about colleagues whom you can collaborate with. You need to know what kind of research you want to conduct, and you have to be realistic about the feasibility of that research. You cannot think about innovative medication where you have limited access to innovative labs, radiology, supportive staff. Think about the trials I just shared, the escalation trials. Even if you want to move forward, you have to think about feasible research, have properly written protocol, and reach out with the support of your colleagues from high-income countries. That will give more credibility until you build your own history conducting research in your setting. That's my advice. And it's actually practical from me being in this community for the past 2 decades.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.